Hello, everyone. This is Meera from the Part 3 Summit, one of the mentors. I'm here to discuss about two key domains in Part 3 MRCOG examinations. One is communication with the colleagues and the applied clinical knowledge. Both these domains are essential in terms that it's easy to score and it takes very little time in the 10 minutes station for a candidate to perform. At the same time, it could be one of the most overlooked domains. Sometimes in structured discussions, when a candidate is not strong enough, they're not logical enough or structured enough, this could cost them in the communication with colleagues domain. And some candidates, unfortunately, who are not able to get through in the examinations, they might be shocked when they see that it was not a sufficient level in their communication with the colleagues domain when they see the results page. So this could be shocking. So why this happens is essentially because without a proper strategic practice or overlooking these key domains when a candidate is preparing, that might be the reason. So now we will look at how you would need to be aware of what constitutes the communication with colleagues domain and the applied knowledge domain. So how we go about is we will look at what is a common pitfall for this communication with colleague domain. This I have taken from the Lisa book for the Part 3 MRCOG. Though this book is outdated, this is still relevant in terms of a preparation. In the initial time when a candidate is preparing for a Part 3 examination and you are at the phase where you understand and you incorporate things domain wise in your mind so that by the time you go for revision, things like these should come to you naturally so that you will not be aware that you're talking about points from this domain. That's how you should be practicing. So what are the pitfalls? What are the common pitfalls? Not adopting a logical, reasoned approach to a clinical decision making is something which can happen when an anxious candidate is there in the examination hall, aware that they are being assessed. But a clinician who is practicing, who is given a scenario similar to a station in the examination, that clinician will not miss the points which can be missed by a candidate. So the way in which you can avoid this is by practice, by being confident. The practice will give you confidence and you can be the clinician that you already are. So adopt a logical and reasoned approach to clinical decision making. Why you are doing a particular thing at this point of time. Suppose a patient comes to you with pain abdomen in the emergency department and she has been taking irregular contraceptives, oral medications. You will be immediately ruling out the ectopic pregnancy. So this is something very basic. So this kind of logical approach is what is essential when you are talking to the examiner. Struggling to convey clear and succinct summaries. Summaries should be, whenever a summary is asked in a structured discussion, it should be short, it should be in a structured format, it should not contain details that are redundant. And when not asked, do not summarize. Whenever an examiner is asking what are your next steps, don't go for summarizing. It is not needed at that point of time. Sometimes people will be asking you to summarize and then go for the management step, but that is going to take up your time only and it's not going to help you in any way. It's going to fill your time for something which is not going to be marked at all. So don't give summaries unless asked. And when asked, go for a very short and concise summary which is relevant. Failure to use a structured system of communication, the S-bar tool. One of the most important things, most of you who had been preparing for some time will know it. We will be looking at it in detail format for those of you who are new to this. Problems with legible writing legible, logical, and ordered clinical notes, plans, or operating notes. But sometimes you might be given the discharge summaries, the notes which are out there, and you will be asked to critically evaluate or add or detail some points. So there, if it is not legible, if it is not uh, ordered in a way, it can be a pitfall. Not understanding diverse roles and dynamics of a multidisciplinary team. So this is one of the most important things. Usually a candidate who thinks they are performing well in communication with colleagues, they say that I'll be involving the MDT and move on. You need to understand that an MDT is a formal team, like an onco MDT, endometriosis MDT, where there is a formal multidisciplinary team which is functioning. So this is different from a multidisciplinary management for a patient who is being, evaluated or managed for a maternal medical disease or any other disease which involves people from various disciplines. So this is something which is very categorically different. A multidisciplinary team, which is a formal team, is different from a multidisciplinary involvement. So this you need to understand. Now, whenever you talk about communication with colleagues domain, usually you will think of these things: the teaching station, letters to the GP, which is there previously, handover, how we hand over in terms of SBR tool, involving the MDTs, sharing information to the GPs, midwives, and other healthcare providers, right? So these are the usual things which will come to your mind. Other than this, there is also the way in which you communicate to the role player about how you're going to manage, and way you talk to the assessor in a structured discussion, your body language, your tone, your ability to wait for the next question. So all those things are surreptitiously going to be assessed for the communication with colleagues domain. Apart from that, the support groups are also important part of the communication with colleagues domain. I have compiled here some of the important support groups, because essentially these are also people who are going to help in the management. I'll be putting you in touch with the support group. It's better to mention the names of the support groups, like SANS for the stillbirth and neonatal death, Tommy's for the pregnancy loss, the Verity support group for the PCOS, DAISY network for the menopause support group. So at the initial point of your preparation, if you try to mention these things, by the end, you will not take it, upon you to read up something which is new. So this will help you score more. So the key points of how you deal with this communication with colleagues, I have compiled it here. This includes the verbal and written communication skills. You are going to showcase there to the assessor out there that you are communicating with the colleague. The best way to do it is to mention this at the start of your management plan. Suppose you are going to start with the management plan, start this with the colleagues aspect. I'll be involving team from various disciplines, including this. Or when you are in a structured discussion, the treatment is going to be in multidisciplinary, involving this. So you will never forget this aspect. But sometimes what happens is, in a long station, like maternal medicine station or urogeny station, essentially what happens is you try to talk to the role player, trying to chunk the info, get the information from her, answer to her questions. So by the time, you will not be aware that you missed the communication with the colleagues aspect totally. So you start the management with communication with the colleagues, and also keep looking at the candidate instructions. Sometimes the information will be from a GP. You need to write back to the GP. You need to close the loop. Right. So these are the small points which might be overlooked, but with practice, these things will come to you naturally by the time you are in the revision. So this includes verbal and written communication skills. As such, when we are talking about communication with colleagues, apart from the exams, this involves the operation notes, the referral letters, the discharge summaries, prescription, the GP letters, right? So this is how we communicate. We take over, we hand over, we talk about the patient to somebody else. We involve other people in the care where we discuss about this patient. And in a structured discussion, you're going to discuss about a patient. So essentially, all these will come under the communication with colleagues. Safe practice depends on effective MDT communication because no doctor is an island. We are working in a hospital or in a unit where a lot of people come in to care for an individual patient. So essentially, this is a safety, right? Communicating with others is a safety. Communication should be succinct, relevant, and structured. Structured is something which is very difficult to practice, but once practiced, if you are a good candidate who is performing well in a structured discussion, usually you will be able to pass the exam. So the way in which you structure your task, you structure your points in your mind when you're talking to the assessor, this goes a long way in helping you score more, right? So avoid redundant long discussions, following templates. Like when you're doing an ST, what candidate does is they'll be telling all the points that they will do in an SPT. That's not how we do it. When you are talking with the colleague, suppose a person whom you are working with, this is not how you talk. I'll be asking this. That's not how you will ask. So I was thinking in terms of this. So I asked this, I ruled out the other things, and then she presented with this. That's how we talk, right? Let it be natural. So when you talk that way, you will not be following a fixed SPT, which is changed into SD format, and it will not look very monotonous. It will not look very rehearsed. So the discussion should follow very naturally. So that comes in with practice. That comes in when you are a confident candidate, right? Include essential positive findings, relevant negatives, and pending tasks. Sometimes what happens is a lot of papers are given to you in the exam. You will not be able to take in because you are overwhelmed. Whatever is there, whatever is not there, because again, you are assist, you are under the line, the microscope, right? So what happens is you will be overlooking certain factors which is not mentioned there. So you need to take this, whatever is not there, and you need to ask the assessor, what is the finding there? What may I know this? May I know the next finding? Right? So that needs to be elicited. And if it is an SPT, again, that needs to be arranged, right? Use logical, clinical reasoning and clear management plans. Just because something is out there, don't offer all kind of next investigations which are not needed. Your management plan needs to be clear. Structured handover such as SBAR, which is important. Ability to summarize key information clearly is essential, and documentation should be legible, dated, time, signed, and include designation. This could be essential when there is a referral letter or there is a discharge summary prepared by another colleague, whom somebody is asking you to go through that. So you need to look for all these things. Whatever information is given, whether it includes the essential things like these, and whether it includes red flags, and whether it is dated and essential information is added out there. Handover is a core safety skill in labor ward and emergency care. Ability to prioritize and triage workload is assessed in the communication with the colleagues aspect. Suppose there are 6 rooms in the labor room and you are asked to prioritize. You go to the most the urgent room, and you need to take up by yourself or the consultant according to the availability, right? So whether you are doing that is also the communication with colleagues domain. And triage workload. So you should know the levels, the hierarchy, who can be given what kind of work. So a labor ward coordinator who is a senior midwife is at par with the consultant. This is a senior person. So you can offer them to manage a case who is serious or who needs that level of care. So this you need to know. Labor ward coordinator is not any other midwife. And some usual episiotomy and usual labor care can be done by an usual midwife. So this you need to understand. Communication should support continuity of care during shift changes. So practically, this is what is this domain about, right? Understanding the MDT roles, work collaboratively with midwives, nurses, and allied professionals. So the midwives are an essential level, an essential people who are involved in the care, in the labor. And sometimes you will be looking at patients, looking at stations where patient is in midwifery and some issue like meconium stain like her, or she might have high BP which requires or fetal distress, or she is in labor for a considerable time, non-progress, she might be needing to be transferred to the ops unit, right? So at that time you need to mention this to the role player in a way that you tell them that we are going to transfer you to the ops unit in view of this. At the same time, you should not be undermining the people who are working in the midwifery. That shift is essentially for the patient to get an adequate level of care for that particular status that she is in, right? So this needs to be mentioned in a way that you are not undermining the midwives. And even after she is being shifted to the ops unit, she will not be directly seen continuously by the consultant. There also, she will have her one-to-one midwife, and she will have access to the theater, to the neonatologist, to the labor room, the blood bank, all those facilities, which is going to be available. So that's how you are going to score in this domain, in the labor room task, right? Know what can be delegated and when to seek senior help, right? So the certain things you need to mention this at the start. Like for example, if there is a PPH and you start managing, and by the time you finish, sometimes you might miss mentioning who are the colleagues that you are going to get help from. So start with calling for help, right? That's how you will ring the buzzer, right? So that should be mentioned when you are starting with the management. Respect protocols, pathways, and team dynamics. Teaching skills are also assessed through communication with colleagues. So this is an entire module where communication with colleague is the main aspect. So here you will be teaching, you will be assessing whether the colleague is understanding, and you will be giving freedom to the colleague to ask questions, and this is going to be a two-way communication, and at the end you're going to get two-way feedback, how you are going, how you are doing, and how the colleague is doing. So this is the mainstay of the teaching station, which is going to help you score with the communication with colleagues. Sometimes what happens is there, if you just go on monotonously with something which you know about a particular station, you go on and on about a lot of things, you might be downscored in this aspect, in this domain. Because if you don't take in what the colleagues is here to learn about, the agenda, if you don't elicit, if you go on and on about what you know about a particular forceps delivery or a vacuum delivery, or you're talking about the POPQ, if you go on and on about something which you are keen or which you prepared, or which some station which you already saw, and if you don't give a chance for the role player to talk, you might be downscored, right? So set an agenda, assess the learning needs, mention what is the importance of understanding about particular thing which you're about to teach, and also talk to the colleague. Talk to the colleague in a way that they are able to say whatever things are their agenda. Like sometimes they might be asked to interrupt, or they might be asked to understand it in a different way for you to pick it up, right? So that should be given an opportunity, that should be allowed to happen for you to score well. So that is also part of the communication with the domain, with the colleagues domain. At the same time, you should be saying it in such a way that you don't undermine. Suppose the role player, the teaching station, the role player is saying something or doing something which is not a safe way of doing it. You should be mentioning it in such a way that you don't undermine them. Is it not a better way to do this the other way around? Because essentially we want to avoid this, which is why we emphasize on this. So instead of you do not do this, you should not do this, no, 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 instead of all these ways in which you might say, you would need to be doing this in a way that you are not undermining. So you need to use a lot of passive sentences. Instead of should, you should be using you would need to, it is better to. So this way it needs to sound polite. At the same time, you need to emphasize this point, because usually the points which you're going to mention this way are the safety points. The common pitfalls here could be poor summaries involving a lot of information that is going to be redundant, lack of structure, following a fixed template which you prepared instead of what particularly is there in front of you, weak MDT understanding, saying MDT as an umbrella statement for all management, failure to use the SBAR tool. These could be the common pitfalls candidates can do whenever they try to score here. So what is this SBAR? This is for beginners. So SBAR is about the situation, background, assessment, and the recommendation you are going to do when you are talking about a certain situation, certain patient detail to a colleague, or during a handover, or during an emergency, right? So what happens is, I am in a teaching institution where when the postgraduates are coming to me and telling me about the certain details about the patient, they will start with, she is a 42-year-old, P2L2, previous 2 vaginal deliveries, and sterilization done. She has had bronchial asthma for all these days. So by the time they come to what is her primary concern, I would have forgotten all these details. So a lot of this information at this point of time, initially when I'm hearing about this patient, is redundant. It's not necessary at all. So start with whatever is the situation. So this is the yes here in the yes bar. The situation is, I am so and so. I am going to talk about a patient in the ward, and this is a patient in the OPD or patient in the emergency. She has come with this complaint, or she has a shortness of breath. And this is a patient who has delivered right now. She seems to be having PPH. There is a massive PPH. She has lost about 2 liters of blood. So here you are talking about the quantification also. So this is the situation. Right? Identify yourself, I'm so and so, and mention the patient by name and the reason for your report, and describe your concern. The patient is crashing, her BP is not recordable right now. She is a patient who delivered. B is the background. She is a patient who delivered half an hour back. She is a multigravida. She has had a prolonged labor. So these are the details you think are relevant to the situation. So give the reason for patient's admission. Explain the significant medical history. Here, you need to tell about the background. This is a patient who had undergone a hysterectomy. She is a patient with a high BMI. She had been on HRT. So this is the background information which you need to give in the B. And assessment. Right now, what are her vital signs? So you have assessed her. So her BP is this, her SpO2 is this. So she seems to be crashing. She has developed chest pain. So this is the assessment and your recommendation right now, what you would need to do. So I would like to do these things. Please come and review the patient immediately. So this is the recommendation you are putting out there. So this is the S bar: situation, background, assessment, and the recommendation. It doesn't mean that you are going to say each things in terms of the situation is, and the assessment is, and the background is. So you're not going to say this way. You are just going to adopt this format whenever you are talking about a management. So if this format is what you adopt in the labor room also, in the labor room prioritization also, it's going to be a very good way. So what happens is, when you're given a chart, what the candidate does is, they'll just read whatever is there in the she P2L2, Mrs. So and so, 43-year-old on epidural. So they'll read all those things. Instead of that, they can just mention multigravida in labor, or patient who had delivered on the ventilator, or a known case of preeclampsia, her BP is high, 43-year-old. So if you mention this way, about the situation. It's very apt and it's concise, and it shows that you throw light onto factors, stuff which is relevant, right? So adopt this approach when you are talking, rather than essentially saying yes is, B is, A is, R is. All right. So usually this read back is something which is usually avoided, because this is an assessment, and this is not necessary for us to know about, because this is why which is this is usually overlooked. Usually what happens is, whenever somebody is handing over about the patient, they'll tell all the S bar things, and then the receiver is going to read back. They will mention all these things to show that they have understood whatever information they have received. So this is the read back. So just for you to know about this. So essentially what you need to know is what constitutes S bar and how you are going to mention things in the S bar format. I hope this is clear. Now coming to the way in which you are assessed in a structured discussion. One of the key stations where communication with colleagues is being assessed. So you will be out there alone with the SSR, and the SSR is going to have a single expression. They'll not be happy or sad with your performance. They'll be asked to make. So in an SD, when you are in front of an examiner, this is a station where the communication with the colleagues aspect is going to be assessed, and where you can score very well. It's going to improve your overall score. That will help you get the pass, right? So here an examiner is going to ask you questions, and you need to communicate in a way that you look respectful, at the same time confident, humble, and you need to showcase how good a clinician you are when you are given certain facts, right? So sometimes what happens is, they will be looking at the examiner, and sometimes if the examiner is not reciprocating their expressions or happy with the expressions, the candidate might feel lost, right? So don't be lost that way, because they are instructed to do so. They are instructed to maintain a neutral expression. So an assessor in the SD station is going to look at you. Even if you say the correct answer, they are going to wait for you. And if you say the wrong answer, they will not be saying anything. It's the same expression. So say things which you think are right. And if you don't know certain things, make sure you involve people. Make sure that you mention that I'm not sure of this. I need to look up on this, and say things which are safe to say, right? If you are thoroughly sure of whatever points you know at that point of time. If you don't know, just say I don't know. And make sure you allow the examiner to ask you questions. Sometimes what happens is, the candidate will go on, and they might say answers which are not relevant to that particular question. You need to be concise, and you need to be precise to that particular question, because whatever you are going to say, if those are the answers for the next question, you are not going to be given marks, because you already said this in the previous question. Okay, so answer to the point and wait for the examiner to ask further questions, right? And there are certain stations where there's going to be only one question, and you are going to go on and on about the whole scenario. So in those stations, you look at you pause and see if there is any more questions coming up, and you go on. So essentially, be aware that there might be questions coming up, and be precise and concise, and don't be very underwhelming. Don't be very anxious, sweating all over, and trembling in front of the assessor. They are your colleagues, which are going to help you, who are going to help you to get a pass. All right. Say they are essentially there to help you to get a pass. So have that in mind, and just communicate with them like the way you talk to your colleague in your own hospital. Right? That's the mindset you need to develop. So we will be looking at the various modules, and under these modules, what are the points which will be assessed under this domain. So in teaching domain, which is the most important domain for the for the communication with the colleagues aspect, you will be using a language and other tools to teach, and you will be using a language which is like how you talk with the colleague, and you will not be using a like medical non-medical term, like a layman term to your colleague. You can essentially use all the medical terms. Setting objectives and demonstrating appropriate steps in teaching to accomplish task objectives. So here you will be looking at what the trainee is here to learn about, and you would be telling them why this is important to learn and why this particular thing is essential, and how this is relevant to day-to-day practice, and you are going to go about, not that you are going to talk about the whole detail of the information or the topic which is given, and give feedback. So you are learning well. Yes, good. You are understanding. So this should not be very superfluous. Oh, nice. You are a very good learner. So don't be very superfluous, overly showy this way. Just the way in which, yes, good, excellent, very well done. So something like that, just one word and go on. It need not be very over the top, expressive. All right. So at the same time, make sure that trainee also gives you the feedback. The feedback needs to be two-way. So this is about the teaching module. In core clinical skills, you'll see a lot of structured discussions, and this is the module where you will get stronger in the structured discussion tasks. Mention the documentation, demonstrate ability to teach surgical skills, sometimes surgical points like electrosurgical aspect, or the lab entry you might be asked to teach where it can overlap with the teaching station. So you need to demonstrate the skills, knows what to do and when to call for help. So sometimes there might be a bladder injury. You will be mentioning, I'll stop the procedure. I'll be informing the consultant and inform the theater staff and the anesthetist. So this needs to be mentioned, right? And knows how to prioritize patient on a waiting list. Suppose sometimes the patient might be having latex allergy, or patient might be diabetic. Those patients, you are going to put them at the top of the list, and you're going to mention to the assessor that why you are going to do this, right? So this is also a communication of the colleagues aspect. In post-op module, the same way as a surgical module, structured discussion form the mainstay. Appropriate handover of patients involving others in patient care, especially when complications arise. This management is going to be multidisciplinary. This needs to be mentioned. And use the SBAR communication tool. Do not go on and on. Don't summarize unless asked. Antenatal care is essentially easy. You just mention the teams which are going to be involved and the support groups which might come in. Maternal medicine, again, a lot of other disciplines are going to be coming into view. Management of labor, this is by how you prioritize, right? How you take care when a room is there where an emergency is going on at the same time. 2-3 emergencies might arise, whom you are going to delegate it to, whether that person is skilled to take care of that, and how you're going to communicate to the consultant about this, how you're going to communicate to the assessor about what you are going to do in a particular room. Essentially, if you follow the SBAR format, which I mentioned previously, this is going to be saving you a lot of time in the room, because yes, sometimes candidates just read from the paper. It's going to take up a lot of time. Management of delivery. Sometimes in this delivery module, you need to mention essentially how the other colleagues are going to help in an emergency like hemorrhage or rupture or inversion. What are the next steps that you do, whom you will call? All those things will come under the colleagues domain. Again, postpartum problems will involve other disciplines like neonatologists, GP for follow-up, midwives for follow-up, and mental health aspect, perinatal mental health team. These are essential parts in postpartum problem. And similarly, in gynecology, subfertility, the essential other disciplines which you will mention. Right? Sometimes in SRH, what happens is sometimes you will be in the gynae OPD and SRH case will be coming out to you, and sometimes you will be in the gum clinic. At that time, you should not be mentioning, I will be sending you to the gum clinician. So you are the gum clinician sitting there. So this is situational awareness is essential when you are communicating with the colleague aspect. So you need to imagine where you are, so that you don't redundantly say, I'll be sending you somewhere else where actually you are sitting. And sometimes it will be like a colpo clinic. The next step is going to be colposcopy. I'll be sending you to the colposcopy clinic. Is essentially wrong, because you are the colposcopy clinician and you are going to be taking care of the next steps. So understand that, and understanding the starting point and being aware of the situation is essential, right? So that finishes our communication with colleagues aspect. Any doubts so far? Hello everyone, welcome back. This is about the applied clinical knowledge, which we will be seeing about how we can score here and how usually this can be overlooked when a person is too much oriented in talking and gaining things and gaining trust from the role player and trying to talk about the necessary next steps, how this can be overlooked, right? The similar way in which we talked about the communication with colleagues aspect, let us see what can be the common pitfalls. Patchy knowledge, where gaps are exposed by intense assessment of a 10-minute task. So there are certain questions, there are certain stations, especially the structured discussion stations, where there is a question which is going to ask a particular thing which might be a thing which you overlooked or which you didn't give time to or which you are not very sure about. So that might expose the gap in your knowledge. So it's better to say outright in an outright fashion where you are not aware. I'm not aware of these things, instead of blabbering or saying things which are not right. You just mention I'm not aware and move on to the next question. And to my understanding, to my knowledge, if you say that for this, I'm not sure, I will be concurring with my consultant or I'll have to look back at it. So this way you can showcase that you are safe, but it's going to downscore you. But then it's somewhat in an honest way, showing that you actually are an honest person. So this patchy knowledge can be exposed. So how can we as a candidate overcome this? By updating ourselves, by keeping ourselves updated with the newer talks, the guideline updates which can be there, the time from your part 2 to part 3, in the time frame there can be certain changes and certain additions which you need to update. It doesn't mean that you have to sit back and read like how you read for part 2. It's just keeping up with the things on the go, right? So look at the summaries, look at the recordings which can be put up in groups, and just critically see and go through the newer talks in a way that you don't sit back and read each and every single line, but you take in what are the changes and essential aspects which you can take in and reproduce if it is a structured discussion or an SPT based on something which you don't know, right? Adopting a scattergun approach to the task. Sometimes what a candidate does is they'll start from the beginning of the management and end the whole management step and detail the management step, the whole management step to the role player or to the assessor in the structured discussion. So the whole thing is not essential, the whole management step. Like suppose it's a urogyne station, the candidate will start from the medical aspect and they'll go on and on about the various surgical aspects of an incontinence, and finally the last thing which can be done. Till that point they will talk. So apply the logic for that particular scenario given to you, whichever is going to be applicable for that particular patient for that particular time. That is what is relevant. That is the logical approach. That is the patient-centered approach, right? So instead of the scattergun approach where you are going to tell all the important things that will come to your mind, precisely cater the knowledge which you know to that scenario. So that is why it is the applied knowledge, because pure knowledge as such in clinical practice or in the real world, the pure knowledge is not needed at all. How you apply the knowledge which you have acquired so far is going to be assessed here. That's why people who are practicing clinicians will score well in this applied knowledge rather than people who sit back and keep reading for the exam. Slavishly following a pathway by failing to understand which are relevant parts of a guideline to apply to this task. You should not be blindly following the guideline, right? For example, for a patient who has come to you with dysmenorrhea, and she has heavy menstrual bleeding, and she doesn't want any, she's not keen on using any LNG IUS. She needs something like NSAIDs, which will help you, which will help her, right? So instead of that, if you say that LNG is the best step of management for you, this is the first step, and if you go on and on about something which she doesn't want, which where something else might be helpful for her, that is not the right way of approach, right? So you might be downscored here in the applied knowledge. So for that particular patient, for that particular time, what might be applicable with all the points which you have taken in the guideline, how a certain aspect of it is going to help the patient for a given period of time is what is the applied knowledge. Not understanding the significance of comorbidities in modifying standard care. Sometimes, for example, if you have a patient with ectopic pregnancy looking for medical management, you need to rule out certain things where methotrexate might be contraindicated. She might be have had some liver problem. She might have some gastric ulcers where this methotrexate is a contraindication, right? So you need to showcase that you are a safe doctor by looking at the comorbidities and by mentioning that you will look for this before you offer this approach. So this needs to be mentioned. Not listening to patients' wishes in respect for her care. That's also part of the applied knowledge, which might be overlooked. Sometimes the candidate, the role player might not want a step. She might be keen for various reasons. Sometimes she might not have support. Sometimes she might be planning for a fertility. And if she's planning for a fertility and if you give her LNG IUS when she is having heavy menstrual bleeding, that's not the best way, right? So you might go in with some medicines, tranexamic acid or NSAIDs for that period of time, or even OC pills, which will give her contraception for a period of time. After stopping this, there is going to be resumption in fertility. So this is how you are going to cater the guideline and take her preferences into consideration, so that you are going to apply whatever knowledge you gained in the guideline. So this is how you showcase. So what constitutes applied knowledge? Assesses the ability to apply knowledge safely in real clinical scenarios. Like how we discussed, if there is a patient sitting in front of you with, say, for example, a missed abortion, right? She has a missed abortion. There is a scan with the findings showing some sac size over 25 millimeter. There is no yolk sac, there is no fetal pole. So you need to apply your guideline to say that this is a missed miscarriage. And you need to apply the guideline to ask her to follow up. So you would need to come back in 2 weeks to see if there is any change or if there is any development. So this is how you apply the guideline. So diagnosis here is missed miscarriage. This she needs to know. The next steps as per the guideline is a scan in again 2 weeks, or according to whichever is done, like PET, VS or TAS. According to whichever scan is done, you need to repeat the scan to see if there is any development. And in the meantime, you need to mention about the red flags. If there is any bleeding or heavy bleeding or any other complaints, she needs to contact immediately, and you need to share the 24/7 contact number. So all these things, how you apply the guideline to the patient care is essentially is what is assessed there. Focus is on clinical reasoning, judgment, and decision making. Why a particular line of care is safe for a patient. Suppose there is a patient with heavy menstrual bleeding and she has background risk for endometrial hyperplasia. Without assessing her endometrial status, whether there is any hyperplasia at all, before that, if you offer her endometrial ablation, that is going to be a problem, right? So the way in which you talk to the role player, so we will be doing these steps in order to rule out this, because this essentially is a step where the inside of the lining of your womb is going to be destroyed. So before that, we need to make sure there is nothing sinister going on there. So this needs to be mentioned. So mention this logical reasoning behind your next steps which you're offering to the patient. Candidates must integrate evidence-based medicine with patient-centered care. It's not just stepwise management, whatever is given in the NICE guideline or the GTG. As per the patient, as per her status, whatever is applicable needs to be mentioned. Knowledge alone is insufficient without appropriate application. Like I previously mentioned, pure knowledge is not needed at all. How you apply matters. Clinical decisions should reflect current guidelines and best practice. Demonstrate understanding of common and emergency obstetric and gynecological conditions. You need to know about the basic steps. For example, if there is a PPH management, you need to mention steps in a logical fashion. You should not be missing out on doses. You should not be missing out on contraindications. You should not be missing out on what are the next drugs that you will use and how you will give them, right? How you are going to monitor them, how you are going to go for the next decision step based on the patient's condition. So that understanding of common emergency conditions you need to be thorough about. Examiners assess how candidates prioritize investigations and management. You should not be giving out all the investigations. Whatever is applicable, whatever is needed at that point of time needs to be mentioned. Candidates should justify decisions logically and safely. Communication and clinical knowledge are closely related in stations. The division in the domains is essentially for the assessment. But if you take even one single point, you can argue that in terms of whatever domain comes to your mind. So the same thing can be a safety domain, same thing can assess your knowledge, same thing if you mention this can come under communication with patient, right? So these are overarching domains. So you need to show and tell and reason in a way and explain that in a way that it is showing you that you are a fit candidate to get a pass. Candidates should explain management plans clearly and logically. Don't ramble or don't overload and don't follow a template answer or a model answer which is out there with AI. Use your own understanding, reasoning, especially in structured discussions. Usually what happens is when a candidate is changing the SPT to an SD format, a lot of things which are not relevant comes up. So these things can be put together in a way that it sounds very natural for you to communicate it to a person who is going to be working beside you, right? So I'll be gathering information like whatever happened so far, what are the treatments so far, why she was concerned, and what is the current concern right now. At the same time, I'll be ruling out certain other things also should be mentioned, and your steps should be very logical. There is a very famous station, the hyperemesis gravidarum station. A patient comes up with the nausea, vomiting during the early pregnancy. So a good candidate should think about what drugs she was taking and things apart from the usual the hyperemesis situation. It could be gastroenteritis, it could be a gastritis, it could be a surgical cause like appendicitis, pancreatitis, where she presents with vomiting. So a candidate who is thinking in terms of that, and when he is showing to the assessor that yes, these might be the reason, which is why I will ask this history also. If you mention this way rather than I'll ask this, I'll ask this, I'll ask that, instead of that, if you show your thinking to the assessor, this is a candidate who is fit to pass, right? Candidates should explain management clearly and logically. This is very important. Ethical and legal aspects may form decision making, part of decision making. Like, for example, there is a patient with Jehovah's Witness with in underage age group, right? And that person might deny a blood transfusion. There, you need to be mentioning to the patient that because you are underage, because this is a life-threatening situation, transfusing blood is going to save your life. So the consultant might take the decision to transfuse blood. You would need to know this. So this needs to be mentioned. This is also part of applied knowledge. Shared decision making should be incorporated into management planning. So this is a shared decision making, right? This is not what you are imposing on her. This is best for you. You need to follow this. It's not how we do, right? They need to understand the pros and cons. They need to understand the options available out them. And you need to offer not doing anything also as an option. So they need to take up a decision based on the information that you give. So allow them an opportunity to talk about their, intentions or concerns. That is going to be a question, and that is where you are going to be marked. So allow them an opportunity to ask. Candidates should demonstrate holistic care rather than isolated factual recall. Sometimes what they do is in the applied aspect, because just they want to showcase, they will tell a lot of information. They'll start educating or teaching the role player what this is. This is not what they want to hear. Suppose there is a patient in maternal medicine station. She has had rheumatoid arthritis for quite some time and she is here taking some drugs and she is concerned about the drug intake during the pregnancy. At that point, you should not be talking about what is rheumatoid arthritis and what it entails and how a pregnancy is going to be affected by it. Of course, you need to mention the important details of how each other will be impacted due to pregnancy and rheumatoid arthritis and vice versa. But you need to understand that there are certain things which the role player already knows, right? You need to mention from where she needs to know. So that starting point assessment is important, and you need to mention things which are relevant to her. Not because you know these things, you should not be teaching the role player about stuff, right? So don't overload the role player. So what are the things which will come under applied aspect in teaching module? Demonstrates the use of knowledge to define teaching objectives. Uses evidence to support teaching methods and feedback. So you'll be also mentioning to the trainee where you should go to read and what you should read and why this is relevant. So essentially, you should be knowing about what exactly this is. Certain stations like PopQ, Eurodynamics, make sure you understand and read about them so that off the cuff, when such a station comes to you, you'll be able to talk about it. There are some stations where forest plot and the RRO or station from stats, if it comes up, you should know something to talk about it. So brush up your part 2 knowledge. It doesn't mean you have to sit and read pages of it, just the essentials of it where you need to answer to the trainees questions to that level. Core surgical skills, where the applied clinical knowledge comes into view by your decisions regarding the obstetric and gynecological surgeries. Discusses the risks, complications, and alternatives to surgery. The alternatives are something which is usually overlooked. Suppose a patient would have come for the next steps following a decision to hysterectomy owing to a fibroid uterus. So, what are the other steps? What are the other options available to her, like UAE, myomectomy? Did she talk about it? Is she aware of it? There is also an option of not doing anything. If that is done, what is the resultant of it? So these things you need to discuss at the initial point, right? The alternatives should be mentioned. So the consent is not just about the risks and complications. It is about the discussion of the option. What are the benefits of the procedure and what complication can arise, alternatives to the procedure, and the pre and post procedural things that we do, and what are the safeguarding things that we do. So all these things will come under the consent station. So every aspect of this will come under the applied aspect. Post operative care manages routine post operative patients and complications. You need to think of certain things for you to be aware. There was this station about the syndrome in the urogynecology, right? So sometimes you need to be aware of it to mention it. If you're not aware, you might as well overlook it. So this is also under the applied clinical knowledge. Uses the evidence to support post-operative care decisions. So this is a patient who is going in for pulmonary embolism. So unless and until this is a contraindication, you will start her on the low molecular weight heparin, right? So you will take the basic bloods and you will start her on low molecular weight heparin. This needs to be mentioned. This is one of the most important points. So this is again an applied knowledge. Only if you know that point from the GTG, you'll be able to mention that. Antenatal care, applied clinical knowledge in the planning and management of complicated pregnancies and pregnancies like FGR. It might come up as an SD, or it might be a risk in the patient where you need to integrate the management for an FGR at risk FGR pregnancy, how you're going to detail the next steps of care involving the repeated scans and the Dopplers, and if at all she is diagnosed to be FGR, what is the plan as per the Doppler findings. This pathway you need to know. Macrosomia, if the baby is found to be macrosomic, what investigations you will do now? What are the next steps when you are planning for surgery? What are the options that you're going to give for the patient with macrosomia? Whether it is wait and watch with expectant management, or you're going to give an IOL earlier to avoid a cesarean section, or you are planning for a cesarean section. What are the pros and cons of it? How you detail it? How you encompass the whole thing in a 10-minute period of time is going to be how you showcase your applied aspect. Polyhydramnios, what are the investigations you will do, what you will think of, whether you have ruled out the anomalies, whether you're looking back at the scans, how are you ruling out any infections, is there any diabetes in the background undiagnosed? Again, you have to showcase that. Multiple pregnancies, what extra care will be there, who will be involved in the care, what type of multiple pregnancy this is. So this thing you need to show, right? In maternal medicine, again, it's something which is very easy to perform because you would have the knowledge from part 2, and you will know about the next steps, what are going to be the next management plan, whom you will involve, the whole thing you will be very sure of it. The aspect which you need to practice here is how you integrate all these things in the 10-minute period of time. Have a strategy to time your management plan in such a way that you don't miss out on essential domains, right? That is going to be the task to practice in maternal medicine stations. Management of labor, again, uses evidence, guidelines, and protocols to make decisions regarding labor care. Again, like a patient is throwing a PPH, patient is throwing an eclampsia. What are the next things that you will do? Immediately, how much magnesium sulfate you will go? Suppose she is going for recurrent fits, how much magnesium sulfate you will go? While you are giving magnesium sulfate, what is the route? What is the dilution? What is the management? What is the monitoring aspect when a patient is on magnesium sulfate? All these things should be mentioned, right? And how you will monitor and where she should be shifted to. The place of care is very essential. Whether you are shifting the patient once she is settled to an ICU or HTU, this needs to be mentioned. Usually the place is something which is overlooked. So the applied aspect of knowledge is assessed by all the measures, right? Where how you are dealing with the patient. So the way in which you do this is imagine yourself in the situation, think and act as if you are in that situation. So what are the next steps you do? That's how you show this to the examiner. Management of delivery applies knowledge in management of delivery, demonstrates technical skills in multiple pregnancy, preterm delivery, breech, and shoulder dystocia. And sometimes in shoulder dystocia stations, what is the first next best thing that you will do? You will ask the patient not to push. If there is any oxytocin going on, you will stop. Okay, you will not do certain things like pull from below. So these are the things which should be mentioned. These are safety points, and also this shows your applied knowledge. Postpartum problems uses guidelines and protocols to manage normal and uncomplicated postpartum care. Usually the perinatal mental health stations, which needs to be practiced very well, because this could be ST, and at the same time, if it is an SPT, you need to show the empathy and mention the points of the management plan, right? Gynecological problems uses evidence critically to support investigations, care plans, treatment options, and counseling. This might look very simple, but gynae stations are very difficult to perform because usually it integrates with other points also. Sometimes they will have fertility, sometimes they will have some other medical illnesses, which is going to complicate the next step. So it might look very long. It might look very long, and you will not know where to start. So in these stations, look at the background, what they're asking for, what is the station about, what is the starting point, what the patient wants, right? So go back to the role player for these stations. Stop where you should stop. Don't detail the whole pathway, right? Subfertility uses evidence critically in management decisions, understand constraints of care, including age, existing children, same-sex couples. This is very easy in terms of applied aspect. Subfertility is a module which is very easy to perform. Sexual and reproductive health, again, applies evidence critically in management, applies correct application of Abortions Act and Sexual Offences Act. Right? So these are the aspects of applied knowledge. So initially from your part 1 to part 3, this is how you are going to be assessed. This is the famous Miller's pyramid, from knows to knows how, and shows how to how you do. And this is where you are when you are going to be assessed in the OSCEs. You need to show them that what a clinician you are to score well in the applied clinical aspect and in the other domains as well. Right, so you should be at the top of the Miller's pyramid. This is just to recap whatever we discussed in the communication with colleagues. Listen actively, be an active listener, communicate clearly, do not overload, be respectful and professional at the same time, be disciplined and humble, work together, mention your colleagues, escalate appropriately, call for help, make sure you don't miss this, document and follow up. Right? In applied aspect, understand the scenario, understand the starting point, understand the situation, applied relevant knowledge, structure your answer in a way that it is not sounding redundant. Don't forget to mention the differential diagnosis. Suppose there is a chest pain, give your differential diagnosis. Not essentially this is always MI. It could be just an infection as well, chest infection as well, right? So give a differential for a particular scenario. Consider risks and benefits, weigh up and individualize the care. Not evidence based. Like evidence based doesn't mean that you go by stepwise whatever is mentioned in the guideline. Think holistically and review and reflect upon your performance so far. So that is going to help you as a candidate and as a clinician also. So this is the strategic part to MRCOG success. Thank you so much for listening. Let us meet again with further discussions. Thank you so much.